My content outline about background of AL amyloidosis, what is the goals of treatment, what is the therapeutic options, and the latest updated guidelines. As Dr. Ahmed beautifully illustrated that AL amyloidosis is the most common form of amyloidosis. It accounts for 70% of amyloidosis at all, and it is characterized by misfolded monoclonal light chain that's secreted from a malignant plasma clone. And unfortunately, it is a delayed diagnosis, as Dr. Ahmed said. It's estimated to be at mean 7 months, and about 37% of participants in this survey report a delayed diagnosis for a year, and more than 10% of them for 3 years after presentation. But take care, the presence of monoclonal gammopathy per se doesn't necessarily mean that the diagnosis is AL amyloidosis. So we should discriminate which type of amyloidosis by tissue typing to confirm that is the case of AL amyloidosis. As Dr. Ahmed said, if we have a pre-symptomatic screening patient with monoclonal gammopathy of indeterminate significance, we should go for tissue typing to detect if it is a case of AL amyloidosis or which type of amyloidosis. And if we have signs and symptoms of amyloid organ involvement, we should go for serum and urine immune fixation plus serum-free light chain. If yes, we will go for tissue typing again. If no, we will search for another cause of amyloidosis. When we are diagnosing a case of AL amyloidosis, we should go for assessment of clonal disease and the organ involvement and the risk stratification and staging by serum and urine immune fixation, serum-free light chain, bone marrow plasma cells, and the FISH to detect the abnormal cytogenetics in our patients. Regarding the heart, we should measure internal pro-BNP. We should go for troponin T and the ECG, echo, and cardiac MRI. Regarding the kidney, we should measure 24-hour renal protein and the estimated glomerular filtration rate, liver function, especially the alkaline phosphatase, and the imaging of the liver span. And don't forget the evaluation of comorbidities. Early diagnosis is the paramount importance for effective treatment and prognosis of AL amyloidosis. What about the prognosis? It depends upon two compartments. The first thing is the organ involvement, and the other thing is the plasma cell clone. And the degree of heart involvement, it is the single most important predictor for short or long survival for those patients. And the number of involved organ, either hepatic or autonomic, it may influence the survival of those patients. What about the type kappa or lambda? In patients with kappa AL amyloid, it mainly in the GIT amyloidosis and the liver amyloidosis, and in kidney, as Dr. Ahmed said, it is mainly lambda AL amyloid, and the overall survival it doesn't affected by kappa or lambda, but it depends upon the higher free light chain ratio and also the percentage of clonal plasma cells in the bone marrow. The staging of the AL amyloidosis depends upon cardiac troponin, internal pro-BNP, and the difference between involved and involved ratio of light chain into stage 1, 2, 3, and 4. We have 3 pillars for improvement of treatment of patient of AL amyloidosis. The first thing is the early recognition, as Dr. Ahmed said before. The second thing is the anti-plasma therapy, and don't forget the supportive therapy for those patients. Regarding the current and the emergent therapies of amyloidosis, the current state is the clonal plasma cell targeting. And now there is an ongoing trial to target the amyloid fibrils by monoclonal antibodies, but till now there is no results from those agents. Our goals is 2 levels of response. First thing, and the most important thing, is the hematological response. And it should be deep, as Dr. Omar said before, and also the timing of attaining the hematological response is a very important point in those patients. And after that, the organ response, and it depends upon the hematological response, and it can delayed after the hematological response. According to the amyloidosis consensus, there is a hematological response, complete remission, which means normal serum and urine immune fixations with normal kappa lambda ratio. very good partial response, the difference between involved and non-involved less than 40, and partial response, there is a decrease of more than 50%, and no response if there is no partial response. What about the organ response is the second pillar. The cardiac response is decrease of N-terminal pro-PNB by more than 30%. The renal response is at least 30% decrease in proteinuria or drop below 0.5 gram in 24 hours without renal progression. Regarding the hepatic, there is a decrease 50% in alkaline phosphatase and decrease in the size of the liver by 2 centimeters in imaging. As we see here, the overall survival is based on hematological response as we see here in the green line is the complete response. As we see, the overall survival is best with patient attaining complete hematological response versus the patient with no response. Not only the hematological, the cardiac involvement per se, as we see here, that the survival is dismal with patient with stage either 3B in the Mayo Clinic stage system or stage 4 in patient with European modification. The timing of response is very, very important, as the cumulative survival in those patients when achieving very good partial response at 1 month is much, much better after 3 months. So timing is important. The second thing is the major organ deterioration. When attaining hematological response by 1 month, it is better regarding the organ response than after 3 months. What about the minimal residual disease? Dr. Omar beautifully illustrated what is meant by minimal residual disease with the detection of the clonal or malignant plasma cells in the peripheral blood on bone marrow that can't be detected by a routine lab. And as we see here, that patient attaining minimal residual disease, in those patients, there is a higher probability of organ response, and also there is a lower probability of hematological relapse. So our principle regarding hematological response, the earlier the better, the deeper the better, and we should search for MRD negativity. But take care, patients who do not achieve at least partial response after 2 cycles of therapy or very good partial response within 4 cycles of therapy, don't wait. Please change to the alternative treatments. What about the upfront therapy? The upfront therapy, the main and the only curative one for those patients is the autologous stem cell transplant till now. So the first step after diagnosis AL amyloidosis, please, are your patient is candidate for transplant or not? As we see here in the 4 largest modern series of autologous stem cell transplant in AL amyloidosis show that the hematological response reaches up to 94% and the overall survival reached up to 11 years. But you should select patients appropriately because they are very comorbid patients. There is a Mayo Clinic eligibility criteria regarding the age 70 or less, performance status 2 or less, systolic blood pressure 90 or more, troponin T level less than 0.06, and the creatinine clearance 30 or more unless he is in long-term dialysis, and the NIHA classification class 1 or 2. Before transplant, we should go for induction to decrease the tumor burden. And as we see here, that the pre-transplant induction independently improve the progression-free survival. In a large series, 84% of patients attaining hematological response after autologous stem cell transplant and MRD negativity, 40% in patients receiving bortezomib before the transplant. So we should go for induction before we are going to transplant our patients. What about the approved treatments for AL amyloidosis? Till now in Europe and US, there is no FDA approved treatment for AL amyloidosis except for daratumumab. Daratumumab is a monoclonal antibody targeting CD38, which is the surface marker on the plasma cells. Other types of treatment is an off-label indication, and the most commonly used one is the CyBorD, which instead of cyclophosphamide, bortezomib, and dexamethasone. And a summary of major study assessing the bortezomib on those patients with endoxan or with melphalan and dexamethasone showed that the complete response reached up to 20%. 5%, and a large study that includes about 1,000 patients showing that the overall survival with usage of bortezomib in about 6 years. But what about the real-world experience? As we see here that the autologous stem cell transplant overall response rate reached 81%, so it's a big winner. The second one is bortezomib-based, it reached about 54%. What about the usage of monoclonal antibodies and the era of monoclonal antibody in treatment of those patients? In phase 3 trials that comparing Cybord, cyclophosphamide, bortezomib, and dexamethasone plus daratumumab, it was remarkable 96% of those patients attaining hematological response, renal response, and also cardiac response, and prolonged the progression-free survival. But unfortunately, 20% of our patient is stage 3B, which is excluded from all trials till now. But if we are attaining a response as rapid as possible, as deep as possible, overall survival may be improved. And now there is an ongoing trial, phase 2 trial, that tracks those patients with stage 3B with daratumumab subcutaneous injection. What about the MSMART 2020 update regarding AL amyloidosis? If we are treating a patient newly diagnosed amyloidosis transplant eligible, we will induct daratumumab plus Velcade, Indoxan, and cyclophosphamide for 2 or 4 cycles. Then we will go for stem cell collection. If he is in complete remission hematological, we will observe the patient or transplant the patient. If we are transplanting those patients, we will reassess after 100 days to show if he is in complete remission, or we will shift for the transplant for relapsed refractory side. What about the transplant ineligible? We can use DARA, Cybord, and reassess. If very good partial response or more, we will observe. If no, we will go for relapsed refractory. What about the treatment of relapsed refractory? Before going to the treatment of the relapsed refractory, there is no validated hematological progression criteria till now to define the progression-free survival through study. The organ progression criteria, it indicates the shorter survival and the shorter renal survival. But take care that the organ progression is preceded by elevation or serum-free light chain, the ratio between the kappa and the lambda involved and non-involved. So please don't neglect the serum-free light chain as a marker before the organ progression. We can use lenalidomide as one of the immunomodulators, but take care, it may increase the serum creatinine and it may progress with patients with proteinuria, and it is effective also in patients that receiving bortezomib or alkylators before. The second one is pomalidomide, achieving overall response rate in 50% with complete remission and very good partial response in 28 patients. Also, the newcomer is the oral ixazomib, which is the oral proteasome inhibitor. It attained about 53% complete remission with 25% complete remission and the overall response rate 53%. What about the monoclonal antibody like istixomab, DARA, idralone combination? It's achieving 75% overall response, complete remission in 56%. The newcomer in all hematological malignancy is targeting the BCL2. BCL2, there is an overexpression of BCL2 antigen on the surface of the cancer cell, so protecting it from apoptosis. And by inhibition of BCL2 by the molecule called venetoclax, it leads to a fraying of pro-apoptotic protein, so it will lead to the programmed cell death. And venetoclax, it had a special consideration in those patients with relapsed refractory, especially in translocation 11-14, which is resistant to treatment by bortezomib, especially in patients with AL amyloidosis, and in DARA refractory, the overall response rate is 65%. So, if relapsed, we will decide if he received DARA before or not. If he received DARA before and bortezomib refractory, we can give lenalidomide or pomalidomide. If not receiving bortezomib before, we can give bortezomib-based therapy. If patient didn't receive DARA before, we can use it. What about the third line? Rarely there is a paucity of data regarding that, but you can consider carfilzomib, venetoclax, bendamustine-based therapy, and autologous stem cell transplant. What about the last update from American Society of Hematology less than 2 months ago? There is an update regarding subcutaneous daratumumab in patient in combination with VCD in patient with AL amyloidosis, 18-mark landmark study, Andromeda trial. An Andromeda trial, it is a phase 3 open-label trial. It has 2 arms. One arm Velcade-based therapy, and the other arm is the addition of daratumumab to VCD, and the primary endpoint is the hematological response. And the primary result with median follow-up 11.4 shows that deeper and more hematological response, prolonged major organ duration, progression-free survival, improved the organ response at 6 months with acceptable toxicity. So it is the first approved drug in the patient with AL amyloidosis. With update in ASH after very long period, it showed that in DARA VCD arm, it is 53 increased to 60%, and very good partial response increased from 79% to instead of 50% in all category of patients, especially a patient with 3A cardiac amyloidosis, patient with stage 3 kidney, and patient with translocation 1114 who are resistant to Velcade therapy. And the cardiac response improved with time, and also the renal response improved with longer follow-up in those patients with no addition of safety signals regarding those drugs. So in Andromeda trial, over 2 years, it significantly improved the hematological remission, and it deepens over time, and also a rate of organ response, either cardiac or renal, it continues to increase without safety signal. So DARA VCD is a new standard of care for patients with newly diagnosed AL amyloidosis. What about the last update of the AL amyloid in NCCN guidelines 1/2022? It said that the first thing, if your patient is stem cell transplant eligible or not. Either eligible or not eligible, the first thing is using DARA in combination with VCD. What about the relapsed refractory? We can use all drugs that I said before. The third pillar is a supportive, salt restriction, elastic stocking midodrine. We can use pacemaker, pregabalin, and nutritional support. To conclude, the most and the important thing in diagnostic patient with AL amyloidosis is the suspicion of amyloidosis, and the early diagnosis is crucial to avoid end-organ damage. When diagnosis of AL amyloidosis is made before the development of end-organ damage, there is a much better outcome. Patient with monoclonal gammopathy of indeterminate significance should undergo yearly measurement of proteinuria and N-terminal pro-PNP. Patient should be addressed to a referral center, and once diagnosing AL amyloidosis, please evaluate for stem cell transplant. Daratumumab is the new standard of care in combination with CyBorD. Be ready to change treatment based on all early reassessment, and the treatment option of patients with AL amyloidosis have broadened and continue to evolve with the addition of the new drug. And for that, thank you.